just needed to move on and get to our next speaker. We don't want to take our time from Dr. Woller. But if you have any more questions for Dr. Sherman, please go meet with him out in the hall. We really do encourage this collective discussion amongst professionals, interprofessional education, right? This is what it's all about here in this conference. So this is exactly what we want to do, so let's continue at it. Oh, and also I forgot to mention, thank you so much for your service. We have a couple of our speakers today who are decorated military heroes, so I will bring those up. Okay, next our speaker is Dr. Scott Woller. Good first name, by the way. Dr. Woller is sponsored by Intermountain Health. Please stand if you're associated with Intermountain Health. All right. Dr. Scott Woller, this might take me a while too. I think it's like a two-pager. Truncate it. Okay, we'll truncate it. All right, Dr. Scott Woller, MD, FACP, FCCP, is a professor of research at Intermountain Health and a clinical professor of medicine at the University of Utah School of Medicine. He's passionate about science and the process of prevention, diagnosis, and treatment of various thromboembolic diseases. And I personally, as a pathologist, when I was doing that, I had a lot of love for thromboembolic diseases as well. So I'm excited to hear his talk. So thank you so much.
Thank you so much.
You bet.
Well, good morning, everyone, and thank you so very much to Dr. Tainter for the kind invitation to be here today and to speak with you. So these represent my disclosures, and I'll just highlight two. The first is that I presently am serving as a co-chair of the CHEST guidelines for the treatment of venous thromboembolism, as well as the co-chair of the peer review committee for the ACC-AHA guidelines that are hopefully going to be published even before the end of this year. I'm going to discuss guidance from the American College of Chest Physicians panelists in the form of what I hope are memorable clinical scenarios today to kind of help this stick. The key areas that I'd just like to touch on with you in these 30 minutes include the treatment and how it perhaps differs among patients with isolated distal deep vein thrombosis, talk about the treatment of pulmonary embolism in unique circumstances, the duration of anticoagulation when a patient has a blood clot, and how we think about optimal dosing of anticoagulants, especially in the setting of secondary prevention, that is to say treating beyond the initial treatment phase, and then a unique population, why those patients with antiphospholipid syndrome. So to level set and kick things off, I'll just begin with this reminder of nomenclature that helps us kind of frame blood clots into one of four categories. Those that are provoked by a major transient risk factor, so think pulmonary embolism following hip or knee joint replacement surgery, severe trauma, long hospitalization, and the like. If that event occurs within 3 months, we think of that as being a VTE provoked by a major transient risk factor. You see the definition for VTE provoked by a minor transient risk factor, arguably among the most challenging population when we think about duration of anticoagulation. Thrombosis provoked by a persistent risk factor, so these are patients who have cancer, are among those at highest risk for recurrent thromboembolism if anticoagulants are stopped. And then you do your due diligence and you just can't figure out why that might have occurred, and those are those thromboembolic events that are considered unprovoked. So let's just jump right in with the first case. This is a 68-year-old woman who has a history of alcohol-associated GI bleeding. About a year before, she was playing with her dog, ended up bumping her leg a week before she came in and complained of it being at least swollen when compared to the other side. You obtain a duplex ultrasound of the leg, and she's identified as having deep vein thrombosis involving the peroneal and posterior tibial veins. However, there's no thrombosis that's more proximal. And so just by way of reminder, DVT in the proximal circulation is that which is in the popliteal vein and north. So this is what it, in effect, is referred to as isolated distal deep vein thrombosis. And the question is, should she be prescribed anticoagulation? So by way of orientation to these slides and the way the information is presented, the text inside the colored box represents the guideline statement surrounding the topic, and then there's selected highlights and the like. The key takeaway, though, for clinical practice is that individuals that have isolated distal DVT can be treated in one of two fashions with the same level of evidence. The first is anticoagulation per routine, and if you were to elect that, it's giving, for example, apixaban or rivaroxaban at the higher initiation phase dosing, and then the treatment phase dosing for out to 12 weeks. Or alternatively, if you elect to refrain from anticoagulation, you can obtain serial ultrasound, and that's defined as 2 ultrasounds about 5 to 7 days apart to affirm that there isn't propagation of that isolated distal DVT into the proximal circulation. That propagation occurs about 15% of the time. The clinical pearls then, in thinking about patients that present with isolated distal DVT, include that if a patient is thought to be at low risk for propagation, then refraining from anticoagulation is advised, and simply obtaining serial ultrasound to refute proximal propagation is reasonable. We recommend no anticoagulation if on that serial ultrasound there's no propagation. We suggest anticoagulation may be elected if the patient propagates, but that progressive thrombus is only in the isolated distal circulation, and then if they're among that minority that propagates into the proximal circulation, why anticoagulation is advised. Just by way of orientation, other guidelines in this space don't address this topic. So the second case is increasingly more common with the tremendous fidelity that we have in our imaging, and that is a patient who presents with isolated subsegmental pulmonary embolism. This is a 54-year-old man who has a little bit of hypertension, returned from vacationing in Australia, shows up at your office complaining of a little pinching sensation in his back when he takes a deep breath. He's diagnosed with pulmonary embolism, but that PE is isolated in the subsegmental circulation. So no thrombosis in the saddle, in the main interlobar or segmental domains, but rather simply in that isolated subsegmental circulation. Do all of these patients need to be anticoagulated? In fact, when we look at the pooled evidence in this space, the most recent CHEST guidelines suggest that if a patient has pulmonary embolism that's isolated in the subsegmental circulation with no thrombosis more proximal than that, and they do not have deep vein thrombosis in their proximal lower extremities, then we can select surveillance over anticoagulation. And it doesn't escape me that this is kind of one of those mind-blowing moments where people say, gosh, we're not going to anticoagulate pulmonary embolism. And in fact, it appears that there's likely a subset of patients where that's safe and appropriate. I'll especially elect this if I have a patient that is minimally symptomatic, and especially if they have an increased risk for bleeding. If we elect surveillance, then we advise serial ultrasound. So you obtain that ultrasound at the time of the subsegmental PE diagnosis to refute proximal deep vein thrombosis, and then perform serial ultrasound as we described. In one study that we conducted, we had isolated subsegmental pulmonary embolism overread by 3 blinded radiologists, chest radiologists, and the false positive rate for isolated subsegmental PE was 66%. And so it highlights the uncertainty surrounding true disease when patients have anatomically limited pulmonary embolism in an isolated subsegmental distribution. Well, shortly after this guideline statement was published, Gregor Legal and his colleagues published this very nice prospective management study among patients with isolated subsegmental PE. they performed an analogous approach where if a patient had isolated subsegmental PE, they ruled out proximal DVT and then refrained from anticoagulating those patients. What they observed by 90 days is that the rate of recurrent venous thromboembolism was 3.1% when they espoused this procedure. That value exceeds our threshold of comfort for refraining from anticoagulation. So this is interval information. And if you drill down on the subsets of folks that had pulmonary embolism with this management study, what we saw is that those individuals that had a solitary isolated subsegmental PE had a very low risk of propagation, just 2.1%, and those individuals that were under the age of 65 similarly had a lower risk. So I would suggest that it's reasonable to consider using this guidance, and I will certainly do so in my patients, especially if they're at a high risk for bleeding. But this is an interval, I think, important study since the emergence of that guideline statement. And these are those clinical pearls surrounding how we think about surveillance and individual patient risk when we elect anticoagulation or surveillance alone among patients with isolated subsegmental pulmonary embolism. So the third case is a 23-year-old woman who has pulmonary embolism provoked in the setting of taking estrogen-based oral contraceptives. She was treated initially with apixaban, 10 milligrams twice daily for 7 days, followed by 5 milligrams twice daily thereafter. She doesn't have any bleeding risk factors. Her renal function is normal. And she's presenting now at the 12-week mark to consider whether she's a candidate to stay on anticoagulation or whether perhaps it might be safe and appropriate to stop her anticoagulants. So to frame decision-making in this context, we can look at the risk estimates for recurrent venous thromboembolism in those select groups that we defined initially, patients with unprovoked, persistent provoking, minimally provoked, and major transient provoking thromboembolism. Those patients that have a major transient risk factor, of course, have the lowest risk. She falls in that highlighted, bolded category of someone who has a minor transient risk factor, why the estrogen-based oral contraceptives. And the key takeaway from this patient population is that the margins of risk versus benefit are especially close. And what I always keep in mind is that while there's benefit associated with continuing anticoagulation for the reduction of recurrent venous thromboembolism, as we see here in the forest plots of the pooled studies looking at risk for recurrence, whereby if we continue anticoagulation, we see a reduction in recurrent VTE. I'll tell my patients that to date there's no free lunch. And that is that in continuing anticoagulants among these patients, we see an increased risk for bleeding. And so when we put this together, we really try to balance these risks. And I'll also highlight that the individual case fatality rate for a bleeding event is about threefold that for venous thromboembolism. Therefore, it's a nuanced discussion with your patient considering their bleeding risk, their risk for recurrent thromboembolism, and equally importantly, their values and preferences. One just broad takeaway when it comes to guidelines and guideline statements, if there's a lot of text, that generally means that there's limited consensus in this domain. If you look at other guideline entities, there's variation in how to approach this patient. However, the CHEST guideline panelists suggest that if a patient has venous thromboembolism provoked in the setting of a minor transient risk factor, then we suggest against offering extended duration anticoagulation in those patients. So one really fun, hot off the presses, a study that I wanted to share with you, and this is a nice opportunity. Thanks, Teresa, for her graciousness in permitting me to send slides after my original slides came in, is this study that was just published within the last couple of months in Lancet. This was a prospective management study that compared apixaban, 5 milligrams twice daily, so think standard dosing, with reduced dose apixaban, the 2.5 milligrams BID. This was done in France. It was a non-inferiority study, and importantly, they had the primary safety outcome of major and clinically relevant non-major bleeding. The key impressive aspect of this study is they followed patients out on average over 3 years, and they were able to calculate a 5-year cumulative incidence of recurrent venous thromboembolism. So in the reduced dose arm, the 5-year cumulative risk was 2.2% compared to 1.8% in the standard dose arm. They failed to demonstrate non-inferiority, that is to say it was a negative trial. Nevertheless, significantly fewer patients in the reduced arm experienced major clinically relevant non-major bleeding. So the way I put this together is that whether you're on standard dose or reduced dose, your risk is actually haltingly low. And even though this was a negative trial, I suggest that there's strong evidence to elect reduced dose apixaban in the long term among patients when you consider extended duration, that is to say no anticipated stop date. And that really has to do with the ground that you're gaining in bleeding risk reduction. So this is all about a net clinical benefit. The authors then suggested that low recurrence rates in both groups and the substantial reduction of patient-important bleeding was reduced, and they suggested that this electing this dose reduction after the treatment phase is very reasonable. Well, patients that have thrombosis in the setting of cancer are challenging. This case is a 66-year-old man who undergoes CTPA for dyspnea, is found to have pulmonary embolism, but regrettably at the same time, cancer is strongly suspected. How do we proceed in electing anticoagulation in these patients? So historically, low molecular weight heparin has been preferred among patients with cancer-associated thrombosis, or CAT. In fact, we now have 4 very well-conducted prospective randomized controlled trials that compared the direct oral anticoagulants to low molecular weight heparin among patients with cancer that favor the use of a direct oral anticoagulant. And so current guidance is that either apixaban, edoxaban, or rivaroxaban may be considered over low molecular weight heparin among these patients. And while the quality of the evidence led to a suggest guidance from the panelists, they upgraded this guidance to recommend, in no small part because of the burden associated with parenteral anticoagulation, perhaps indefinitely among cancer patients. It's important to acknowledge, however, that the evidence does not suggest that all these DOACs are equivalent. In fact, when we look at edoxaban and rivaroxaban, so that's Savesa and Xarelto, the trade names, we saw an increased risk of major bleeding when compared to low molecular weight heparin. That was not seen in the apixaban arm. And there's some thinking that because edoxaban and rivaroxaban are administered once daily, perhaps those peak levels are required to maintain a drug effect over 24 hours may have contributed to that observed increased bleeding risk. The takeaway then in this patient population is that the 10A inhibitors are recommended over low molecular weight heparin in patients with cancer. And if you look at the sub-narrative of this guidance statement, we suggested that if a patient had an increased risk of bleeding, or in particular had a GI malignancy, that's the subset of patients that we saw bleed comparatively more than others, why then apixaban or low molecular weight heparin may be preferentially selected in those patients. So this is the other hot off the presses information that I wish to share with you. And similar to the Renove study, this study was called API-CAT, and it compared reduced dose apixaban, so that 2.5 milligram twice daily dosing, with standard dose among patients with cancer. To be eligible, all patients had to have proximal deep vein thrombosis or pulmonary embolism and had to have been treated for at least 6 months with standard therapy. Then they were randomized to reduced dose versus standard dose. The outcomes were those that we value in this space: recurrent thromboembolism and clinically important bleeding. And in fact, in APICAT, the rate of recurrent thromboembolism in the reduced dose arm versus the standard dose arm was 2.1% versus 2.8%. And again, we saw that significant reduction in clinically relevant and major bleeding with the reduced dose. I would submit to you that among select patients, this is also a game changer, whereby if a patient has cancer and they've completed at least 6 months of therapy, I would consider electing the reduced dose apixaban therapy in those patients, in no small part to further diminish their risk of bleeding and advance that net clinical benefit in continuing anticoagulation in these patients. Well, you know, we talk about the use of anticoagulation for the prevention of recurrent thromboembolism among patients that have completed an appropriate treatment phase. Oftentimes, though, patients will ask, well, what about aspirin, doc? Is there any evidence for me to stop my anticoagulants and elect aspirin? There have been 2 prospective randomized controlled trials in this space that demonstrated that when compared to placebo, aspirin reduces the risk of recurrent thrombosis by about a third, 33%. And so we suggested that in patients who have a history of unprovoked proximal deep vein thrombosis or pulmonary embolism and choose to stop their anticoagulants, if they do not have a contraindication to aspirin, then we suggested aspirin over no antithrombotic therapy for the indication of secondary thrombosis risk reduction. We acknowledge that aspirin is much less effective than anticoagulation, yet the way I'll describe this to my patients is that it falls in that category of the old something's better than nothing. We do have one study that permits us to compare aspirin with anticoagulation in these patients for the secondary prevention of recurrent thromboembolism, and that was the Einstein Choice trial. Those patients that had completed the appropriate duration of anticoagulation and were randomized to either aspirin or to rivaroxaban, in fact, were found to have a significant reduction in recurrent thrombosis in the rivaroxaban group, so about a 70% risk reduction when compared to those patients that took aspirin. And this is why, if a patient is in a space that's equitable in choosing one medication or another, we recommend that reduced dose direct oral anticoagulant be selected over aspirin in patients that elect to continue some medication to protect themselves from recurrent thromboembolism. So I'm going to close then with some guidance that is comparatively new in a unique patient population, and those are individuals who have the antiphospholipid syndrome. As you're aware, APS is a systemic autoimmune disease. It's characterized by both thrombotic, can be arterial, can be venous, but also obstetric complications. The EULAR guidance statement on the diagnosis of APS was just published within this last year, and there are some updates there that I'll just draw your attention to. APS patients have persistent antibodies or a persistent abnormal lab marker of a lupus anticoagulant. And the reason that we were excited about the DOACs in this patient population is because these are patients that even on dose-adjusted warfarin have a high risk of recurrent thromboembolism. So there were 4 prospective randomized controlled trials in this space comparing the direct oral anticoagulants to warfarin. The RAPS, TRAPS, and ORDI-ROS studies all looked at rivaroxaban, Xarelto, ASTER-APS, looked at apixaban. Patients had varying APS antibody profiles, but they all had clinical APS, and they were receiving anticoagulation for that reason. And then patients were variably followed up for at least a year in most of these studies. The key takeaway is that when compared to warfarin, the DOACs were no different in the risk of recurrent venous thromboembolism. However, if we look at the risk of arterial thrombosis, it was actually significantly higher, a 5-fold increased risk in those patients on the DOACs, and the risk of stroke was 10 times in the DOAC arm among patients with APS when compared to warfarin. The authors of this systematic review concluded that these studies don't support routinely using the direct oral anticoagulants among patients with thrombotic antiphospholipid syndrome, and that's the presentation of the guideline from CHEST as well. So I'll close by highlighting then patients with isolated distal deep vein thrombosis, anticoagulation, or serial ultrasound may be selected. Not all patients with isolated subsegmental PE necessarily need anticoagulation. DOACs are recommended in the treatment of cancer-associated thrombosis. Anticoagulation is advised over aspirin for patients that elect to continue a medicine to protect from recurrent thromboembolism in our candidates. And warfarin is recommended over the direct oral anticoagulants for the treatment of antiphospholipid syndrome. I'm going to leave you with one gift, and that is this slide here. That QR code is a link to the Vascular Network, which is a trusted not-for-profit that provides guidance for clinicians, but also is a wealth of resource for patients to understand thrombosis and thromboembolic disease. Thank you very much.
All right, thank you so much, Dr. Woller.